Okay, sorry. That took us a little bit longer than we thought it would. So this is me, Vilmi, and Shay's here with me too.
Hi, everyone.
So we went into quite a lot of detail in our presentation with the intent that you can use this when you're actually in the clinic or wherever you are and you get exposed to a poison that you don't know about. You can actually just look back on this presentation. However, we aren't going to discuss every single slide in full detail. A lot of it has got a lot of detail on it, so don't worry, we'll just have a brief overview and then a lot of the information you can read in on your own time. So if you guys remember, we had a short little poll on the WhatsApp group and we asked you a couple of questions and a lot of you answered and we're very grateful. So we're just going to do a quick overview of that. So first time we asked is, have you encountered a poisoning or an overdose? Quite simple, yes. Most of us has at some point experienced it. So we asked if it was accidental or intentional, and as we suspected, a lot of it was related to para-suicide attempts. There's a study done by the Tygerberg Poison Center, and they found that 65.2% of cases experienced in their study time was accidental, while intentional poisoning only occurred about 34.8% of the time. We asked you whether the patient you had was an adult or a child, and as you can see, adults were quite more common than children. In that same study, they found that 55.8% of all poisoning cases were adults, with women making up more than half of these cases. So the next most important question is, which poisons were ingested? And as you can see, organophosphate was quite common. There's a couple of other ones that you might recognize. Did you manage to, did you know how to manage this appropriately and adequately? Most of you said yes. Did you feel overwhelmed? Again, most of you said less. 26% said no, and I'm going to debate that. So as the slide says, we're going to break it down. We're going to make sure everyone knows how to manage the poisons they get exposed to, and we're going to figure it out from there. So the first part of our slideshow is just a general approach to a patient that comes into your ED saying they took something, they drank something. And as we know, the first place to start in any situation is always your ABCs. Make sure that the exposure that the patient has had is taken away. And then from there, go on to the more detailed inventory of what happened. And then don't forget glucose, because a lot of these patients present with hypoglycemia. Activated charcoal can be used, and get to know your date, get a history from the patient or a family member that's nearby. Okay, so some of the common toxidromes that we just made this little graph or table, just so you can go over it in your own time. If a patient comes in, the patient's not responding, you don't know what the patient took, you can look at this and try and narrow down your differential of what was ingested. Like I said, you can go through this in your own time. It's kind of just a simplification that should be able to help you. This is the same thing, just a different way, just a symptom and then drugs that can cause it.
Also pretty much also just a summary. You can use the mnemonic toxidromes, just help you if you can't. So this is what to look for clinically if you're not able to get a history.
And then obviously we're going to go over to general management. This is kind of just non-specific. Like, again, you don't know what the patient took. They took something, they took some pill or something that they found somewhere. So again, airway, monitor your sats, make sure the patient is breathing, make sure there's a good patent airway, suction for secretions, especially in, we all know the biggest culprit, and make sure the patient is positioned properly to reduce aspirations, as that's quite a common complication. And if you need to intubate, don't be scared to.
So in terms of circulation, you want to keep an eye on your ECG. You can get arrhythmias quite often. So your common ones are your sodium channel blockers, your cardiac glycoside, and then your anti-drugs. So your antihistamines, your antipsychotics, and your antidepressants.
Then a lot of patients present with seizures or agitation. Benzodiazepine is a good first start, like Emily and them said in their presentation. Think about all those things. Important, avoid forced emesis due to risk of aspiration, like we said. A little bit on gastric lavage and gastric decontamination. I don't really think a lot of us would attempt this in a clinic setting, but just in case you were so inclined, there's a little bit of information on it and how to get it done. Then activator charcoal. A lot of us don't know that the clinics actually do stock this, and we're surprised when we asked for it and they do have it. It comes in a little packet. It's quite easy to make. Like this says, it should be considered only in very recent ingestions up to 3 hours after the ingestion. And then there are some poisons or ingestants that it doesn't work for, but we'll cover that on the specific points. Then another important point of your management plan, this is something we only recently figured out. Your poisons hotline is a good go-to if you're unsure. Now let's going to break it down a little bit into more specific poisons. The first one we all know, good old Pinata, quite common in the clinics. This is just basically your clinical features, how it could present. The most severe complication, obviously, as we know, is liver failure. This down there, we go over the toxic dose, what actually counts as toxic for Pinata, and it's actually quite more than you think. 7.5 grams, that's quite a lot. IV overdose is a little bit less. The first point of management, you can consider activated charcoal if the patient has presented within, the 3-hour time limit. If the patient presents days after ingestion, as most of our patients do, then the goal of the management is mostly supportive care for liver failure. And then we all know ACC. So this is the paracetamol treatment nomogram. It is basically, it has to do with your serum levels of paracetamol. So it's not really useful for us in a clinical setting, but if you work at an ED like Barra or Becky, and you can take a look at this, this is quite an interesting point of view. And then you stop ACC once it has reached below the red line. And it's important to note that it's never too late to give ACC, even if the patient only presents after 24 hours, and it's safe to use in pregnancy. This is just the dose, what you do, how you give, IV and oral. This is some side effects of ACC that patients can experience. The most common one is the GI side effects. The next thing we're moving on is your organophosphates.
So they're often found in your medications, your insecticides, and nerve agents. And we all know how they act. So they inhibit your acetylcholine esterase, which results in a buildup of acetylcholine, and then you get an overstimulation of your nicotinic and muscarinic receptors. So these are just your features of how your organophosphate presents. It's got some nice mnemonics that you will help remember. So in terms of management, so we all know to give atropine. It's got your dose as well as when to stop if toxicity develops, and as well as the symptoms of atropine toxicity. Just go back. Sorry, also, I just found this quite interesting. It was something I didn't know. Also, just to give NEB, so ipratropium bromide, it just assists with the cessation of the bronchuria and the bronchoconstriction in your organophosphate overdose.
Okay, the next poison we're discussing is tricyclic antidepressants. I haven't really witnessed one myself, but it can be quite common. And this is just a little bit more into detail of that, how it would present, your toxic dose, possible ECG changes, and what you'll see on your bloods or your blood gas. The management of it, they have quite a long half-life, so it can present quite late. The biggest one that it presents with is hypotension, but usually responds well to intravenous fluids. And there are some things you can do if that doesn't work. You can consider activated charcoal within the time limit. There's a little bit on cardiac dysrhythmias that can occur, and then what to happen if seizures do happen. The next one we all might know. So irritants and corrosives, you have some strong alkalis or strong acids that can cause injury. Just a little table on where it usually causes injury, what usually happens and which type. Like your alkalis cause liquefactive necrosis and generally penetrate deeper, whereas your acids generally are more superficial penetration and therefore generally affect your upper airways more than lower down. So these are your signs and symptoms. As you can expect, a lot of oropharynx symptoms, epiglottis, larynx. Worst case scenario, you can get an esophageal or gastric perforation. And then also obviously pulmonary aspiration is always a risk. Things you should worry about: hypertension, tachycardia, fever, and acidosis. You can also get ocular and dermatological exposure. Usually it causes a type of burn. As you can see here, this is alkali burn to the eye. Corrosive ingestions on your chest x-ray, perforation of hollow viscuses. Good to have an endoscopy, though that's not always possible. Management, important, avoid gastric lavage, avoid activated charcoal, avoid emetics, avoid NG aspiration or any administration of neutralizing agent. If symptomatic, keep the patient NPO, that's quite important. Use IV analgesia, give a PPI. If you worried that the damaged esophagus will not stay patent, you can place an NG tube. Ocular exposure, inhalation exposure. Next step is petrol and liquid paraffin. We all know this is quite common in little kids, where they pick up a bottle that was used for cool drink and then filled with paraffin, and the child didn't know and drank it accidentally. So hydrocarbons, your signs and symptoms: fever is quite common. And then obviously it moves on to respiratory symptoms, aspiration, and some other chronic pulmonary complications like chemical pneumonitis, asphyxia, and pulmonary edema. Chest x-ray, very important in case of hydrocarbon ingestion. Some common findings as depicted in the picture. Management, mostly supportive, especially for pulmonary complications. Pneumonitis, treat with supplementary oxygen and bronchodilators. No prophylactic antibiotics. Prophylactic antibiotics are of no benefit, and then only if there's a secondary bacterial infection would use antibiotics. Ratics. So the common problem with ratics or rat poisons is that it often gets mistaken for organophosphates or organophosphates and rat poison. There's a quite narrow overlap, but the actual rat poison is a choline esterase. So the organophosphate, which is the choline esterase inhibitor, but the other rodenticide that we experience quite commonly is an anticoagulant rodenticide, which works as a form of super warfarin. They are more potent and have a longer half-life than warfarin already. Some signs and symptoms: obviously bleeding from everywhere. The usual cause of death in these cases are GIT bleedings. This is your management. It's quite in depth, a lot of INR, checking your INR, when to start vitamin K, how to start vitamin K, should you start vitamin K. A lot of it is discussed here. You can just go over it in your own time. Antihypertensives.
So the most common ones are your beta blockers and your calcium channel blockers. So it's just your signs and symptoms. So your bradycardia, your hypertension, and then arrhythmias. And then you do get hyperglycemia with your calcium channel blockers. And then just quite important there, your bradycardia and your hypertension is often quite refractory to standard resus measures. So management. So again, if patients present within 1 hour, you give your activated charcoal. And then if they have a significant bradycardia, just to give atropine. And then you give fluids as well as adrenaline if they're shocked. And then if a beta blocker has been included, you can give glucagon. As well as you need to start a high dose insulin infusion, all of which is there. In terms of your antiretrovirals, this is just a table with the common side effects of our common antiretrovirals that we use. Go to the next slide. So investigations, obviously bedside, you want to do your glucose, your urine dipstick, rule out pregnancy, as well as your ECG. So the most common side effects are your hepatic and renal, which we don't really manage at the clinic. So management is generally supportive.
So I know there's a lot of information and we went through it quite quickly, but like we said, the point is for you to have something to refer to. If you're in an emergency situation and you need to look up something, we gave you a broad overview that should be able to help you. So that's it from our side. Is there anyone with any questions?
Thank you. Thanks. Great. So you have an opportunity to just give some feedback in terms of rating and any questions, any comments. Thanks. Lots of very useful information. And I think you're finding a way to give it for people to check on it later. And I think that's useful. It's great. And I think the overview was a useful one. So thank you very much for that. Any comments from anyone? Any questions? Any clarity requests? Yes, go ahead, Dr. Petrol. Go ahead.
Yes, I just want to ask a question to the presenter maybe and to the whole group. If you have a patient who is brought by an ambulance and you don't know what is the drug or the substance that the patient took, what would you do? Apparently, you're going to transfer that patient to the higher level of care, but let's say you not in the clinic, maybe you are the receiving doctor in the hospital and you have to decide the patient is unable to tell you what took and how you would approach that patient.
Yeah, I think you mentioned the helplines. I'm not sure that you actually put them out.
Yeah, I did put the helpline here. So that's actually one of the biggest points of our presentation, which we try to cover is if you're unsure, go over to your general management and make sure that you keep your ABCs intact. You check your circulation, you do what you can in that moment. If you think it's something you can give activated charcoal for, give activated charcoal for. And then the other thing that Prof mentioned is, like we said, the poisons hotline is very useful. Generally, if you have a good idea of what the patients took, you call them. They're very helpful, and they are able to inform you quite easily of what you should do, what you should look out for. But yeah, we would go with general measures. Suspect what you think. Look at the toxidrome, see if you can narrow it down, try and manage from there. But if you can't at all, then just keep your general ABC, general resus principles in mind. I think that's the biggest thing.
Okay, let's say you did all your ABC, the resuscitation approach and everything, and you still don't know, the patient is not able to tell you, and you've sent the bloods to the laboratory, the bloods are still not coming, and the patient is not improving. As a matter of fact, he's getting worse. What would you do?
Well, I think if you're in a clinic setting and
no, you are in a hospital. Let's say I mentioned from the beginning that, yeah.
Oh, in a hospital setting. So I think you just need to make sure that the patient remains stable, because if you don't really know, you'll ask the family or anyone that was around them to call, like anyone for collateral that could possibly have witnessed this. But I mean, if there's literally no one to tell you what the patient took and you can't narrow it down based on symptoms, then I think your best bet was to wait for your blood work and keep the patient stabilized. I don't know if anyone else can think of something else, but I don't think we can think of anything else.
And before you even get the blood results from the lab, the patient is already dead, and the patient is 16-year-old.
Sure, I don't know if there's no way of finding out. You can't call collateral. You can't try and narrow it down based on symptoms. I don't know. I'm not sure.
Okay, let me ask you in another way. Would it be wrong if you give to that patient, let's say it's 16-year-old, what is closer to your mind? Because it's not organophosphate, it's not the other most common, you cannot recognize the features of the other drugs or poison, what patient could have taken. Would it be wrong if you give Parvolex and acetylcysteine to that patient?
I don't think it will be wrong, and I don't think it will necessarily harm. So I suppose, yeah, you could.
Yeah, I agree with you. I would advise you to do it because I had a case, the patient really died. That till I was waiting for the results from the lab, and the patient died. And it was really 16-year-old. Was brought by the ambulance, no relatives, no one could give us. The patient was not able to tell us. We tried our best, and then the patient died before even the lab came with the final that it was a Pinata overdose. So just think. So my question is relating to another question. Do you know how to access the Parvolex? Because before it was easily to access, but now with the protocol, do you know how to access Parvolex?
No, I do not. We do not.
Yes, that is very important to familiarize with how do you access from the pharmacy, because you need to write like an application that you put the name of the patient and you go to the pharmacy, and then the pharmacy must give you against the name of this patient to give you the Parvolex. So don't put yourself in a situation that you don't know how to access the Parvolex. That's another thing, very important. I've got another comment for this warfarin containing poison. Yes, Ratex, yes. Keep in your mind that when the rats are eating that, they get very thirsty. They go and drink water outside of the premises they ate that poison. And once they drink water, they start bleeding internally. So if you're sure that your patient is taken that Ratex, don't give fluids in the mouth. So just maybe contact the hotline, and the hotline can just guide you what to do. Another last comment I want to say, because I see the time is running, is that the same happens with the alkalic poison. The most common one is sodium hydroxide, which is part of the drain cleaners. So patients drink that drain cleaners, and also when they drink water, the esophagus and the stomach become like a soap. So once you mix the sodium hydroxide with water, you produce a soap for washing your hands. You understand? So don't give charcoal with the water in this case. Contact the hotline so they can guide you what to do. Because once you give water and goes through the esophagus and stomach, you produce a soap. Thank you.
Thank you. Useful comments. Thanks, Dr. Petkova. Any other additions? Great presentation. Thank you for the effort. Thank you to both of you for doing a great job, both of the groups. I think we can stop here. We'll see you all next week. Well done. Bye-bye.